Good morning, my name is Lynn Golovic. I'm the orthopedic nursing team leader. We're here for joint education for a total hip replacement. Today, we're going to see people from occupational therapy or physical therapy. They do both portions of it. Discharge planning will come and talk a little bit about what they set up for you when you go home. We'll have respiratory therapy here to talk about using an incentive spirometer and the importance of coughing and deep breathing. Val from next door at TerraceView is going to come over. She's going to talk a little bit about subacute rehab in general and then TerraceView specifically. But usually at this point in time, your doctor probably has told you if he thinks you're going to need to go to rehab or not. Most hips, especially the anterior approach where they go through the front, most hips do go home. Kathy from the VNA Home Care is going to come. She's going to talk about setting how we set up home care for you if you do go home. Somebody from the home care agency would be in to see you. VNA is one of the agencies that you can choose from. They just happen to help us and present at this class. And as far as patient experience, patient portal, we don't have anybody coming in for that. What we do now is we have your email address on the sign-in sheet. You would get an email from somebody from our patient experience department to join the patient portal. And the patient portal will give you real-time access to your medical records here at ACMC. If you want to sign up for the patient portal, there'll be a link on that email. You can click on it and sign up for the patient portal. If you don't want to, that's absolutely fine. You don't have to. Inside of your packet, there is a book on the hip replacement. There's some information for Meals on Wheels. Some people need just a little bit of help when they go home. There's a healthcare proxy form. We encourage everybody that comes into the hospital to have a healthcare proxy. A healthcare proxy allows you to make a decision now of who you would want to make decisions for you if you were unable to make them for yourself while you were here with us. Some people already have a healthcare proxy, that's fine. Bring it in when you come the day of your surgery. We'll make a copy of it and give you back your original. Your signature on your proxy has to be witnessed by 2 people, not you or your proxy. So if you don't have 2 other adults at home to witness your signature, fill it out and bring it in unsigned the morning of your surgery, and 2 people will sign it in room 160 when you come the day of your surgery. There is a list of rehab facilities across Western New York in there too. Although, like I said, at this point in time, your doctor probably has told you if you're going to need to go to rehab or if you're going to go home. And there is a little survey if you don't mind taking a few seconds to fill it out when you're done. Some general information on page 6 of the booklet: visiting hours, telephone, TV, cafeteria. Visiting hours we're kind of lax with. I think our posted visiting hours are 10 in the morning till 9 at night. But we encourage family involvement in our zone. We want your family to be around, especially if you're going to be going home. It's best that your family's around as much as possible because they're going to learn from the therapist how to help you do what exercises that you have to do when you do go home. There is no charge for telephone or TV services. Most people bring their cell phone with them. Just take your charger when you leave. There is a full-service cafeteria on the 2nd floor for families. There's 6 or 8 different stations, all different kinds of foods down there. And then on the ground floor, there's Subway and Mighty, Taco, and Tim Hortons. So before surgery, your pre-op testing is probably going to be happening today after this class. That's usually how we try to set it up. So you only have to come into the hospital one time. That is done in room 160 on the 1st floor. When you enter the hospital, you're on the ground floor. So if you're unfamiliar with the setup. 160 is on the 1st floor, and it is kind of a far walk down the hall. Being that you're having a hip done, if you need a wheelchair when you leave here, we can help you out with that and take you down to 160. 160 is where you're going to go to the morning of your surgery also. There is a list of medications in your booklet that have to be stopped before surgery, and they include any aspirin or aspirin product, Motrin, ibuprofen, Advil, Aleve, any of the NSAIDs, some over-the-counter fish oils, multivitamins, and then if anybody's on a blood thinner, Coumadin or Plavix, those also have to be discontinued before surgery. There is a list in your chart, and when you do your pre-ops, they're going to go over your list of medications with you and give you a heads up of what you have to stop. If your plan is to go home, try to make sure you have someone that's going to be able to help you out. You really don't have to have somebody with you 24/7. You just want to make sure that we have somebody that's going to be able to help you out and check up on you. Some people that have an anterior approach hip go home alone. They live alone, and that's fine. what we do when you're here is we make sure with physical therapy that we assure a safe discharge. So what they do is kind of get your setup at home, how many stairs you have, where's your bathroom versus your bedroom versus where you'll be hanging out for the day. And make sure that they can kind of simulate in the physical therapy gym your setup at home so that you can, so we can assure that you go home safely. You want to try to eat as healthy as possible. Your appropriate amounts of fruits, vegetables, proteins, grains, along with an adequate iron supply from red meats, fortified cereals, green leafy vegetables. The potential for blood loss is there after any surgery, and in orthopedic surgery it's a little bit higher. So we want to make sure we're keeping that iron level up because that's what we lose in the blood. When you come to the hospital the day of your surgery, bring this booklet with you, along with some comfortable walking shoes. And hopefully, by the time you guys have surgery, we don't need to worry about snow outside. But you want to make sure that you have something comfortable and safe on. Step-in shoes are not a very good thing. Clogs, or depending on time of year, flip-flops, you don't want to do something like that. Sneakers are the best and the safest. Make sure that you bring a brush or a comb with you, glasses if you have them, dentures and supplies, hearing aids. If anyone uses a CPAP or a BiPAP machine, a lot of people like to bring theirs with them to the hospital. Your mask has been fitted for you, and it's usually a comfort level. We do have them available from our respiratory department, so if you do have a CPAP or a BiPAP and you need to use one, if you don't bring it, we can get one for you. Please do not bring any of your home medications with you. We're going to give you everything the doctors want you to continue while you're here. We're going to give you when you're here in the hospital. We scan everything in with your name band and all the medications are scanned in. The morning of your surgery, you're going to take whatever meds you've been instructed to take with just a little sip of water. Again, they'll go over your list of your home medications with you today when you do your pre-op, and they will let you know what you need to discontinue and what you need to take that morning of surgery. If you're diabetic, please do not take any of your diabetic medications the morning of your surgery. We will also test your finger stick 4 times a day. A lot of people that are non-insulin diabetics don't do it that often, but we will do it when you're here. We'll test your finger stick 4 times a day, and we'll make sure that that we're keeping your blood glucose under control. You want to bring your picture ID, insurance card, and any copay that's due for an inpatient stay when you come to 160 the day of your surgery. You're not going to have anything to eat or drink after midnight. You're going to be given 2 different times from your physician, your time of arrival and your time of surgery, and it's usually a couple hours in between. You may not get that from your doctor until a day or 2 before surgery, and that's okay. That's how they set it up. That sometimes the doctors do wait until they have everybody's medical clearance before they actually set up their surgery schedule. So you know the date that you're having surgery, just not the time. When you go to 160, they're going to take the patient in the back, get you in a gown, and then usually they let your family come back in with you. They call it minimal separation. They want you to be comfortable, and normally your comfort level's with your family. You will meet your surgical nurse, the anesthesiologist, and then the doctor's going to come. He's going to confirm what he's doing, left hip, right hip. He's going to take a Sharpie and label it. He's the guy that's going to let you know how long surgery is going to be. An anterior approach hip is usually about an hour. And then we just ask the family be back in the waiting room to talk to the doctor after surgery. Question?
Wow, an hour?
Mm-hmm.
It's amazing.
Yeah, the anterior approach. If you're having the posterior approach, it's a little bit longer, but the anterior is about an hour. Your family will be given an ID number to follow your progress on a big screen TV that's down in the waiting room, and it kind of lets them know what point in surgery you're at. After surgery is completed, though, the doctor will speak to the family with an update, and then when the patient's ready to be released from the recovery room, your nurse in the recovery room and the PACU will call up here to the nurse that's going to be taking care of you. We do our best to try to pre-assign room numbers, so sometimes for family members' benefit, we are able to pre-assign room numbers. We can't do it all the time. Sometimes we have to wait for discharges to happen before we're able to assign room numbers. But if that is the case, what we've begun using is this room, 685, for family members. So if your loved one's room isn't ready, you are welcome to come up here to 685, and we have the same setup with coffee and snacks and the TVs on, just for your comfort level. Dental prophylactics. If you have been told already that You will need to be pre-medicated before going to the dentist. And it's, depending on your physician, it could be for a lifetime or it could be just up to 2 years. The pre-medication is an antibiotic. It's normally amoxicillin unless you have an allergy to it. And the reason for this is any infection that enters your body can settle into your new joint. So of course we don't want that to happen. So amoxicillin is, again, one of the medications unless you have an allergy to it. You would take 1 hour before any dental procedure, even just a routine cleaning. And the reason for it is any infection, like I said, that enters your body can settle into that joint. If you think about the bacteria that we have in our mouth, you go to the dentist today, you have a cleaning done, and you get a little redness on your gum. Tomorrow morning, it's gone. When you have this new joint, anything can settle into there. So a couple of things the doctors have asked us to say. They don't want you to have any routine dental work done between now and surgery date, and then for up to 6 months after. So your best bet is before you go to the dentist for the next time, you check with your surgeon's office and get their approval. Okay? Any questions on that at all? So your inpatient stay. You're going to wake up most probably with 10 stockings on. These are to help prevent blood clots. If you do have these on, we'll have an order for you on discharge too, that you would wear these when you go home. Again, each doctor is a little bit different, but we will go over all that on your discharge instructions. You will, though, wake up with some type of a compression stocking on. These hook to a machine that sits at the bottom of your bed, instills air to promote circulation. We have a foot pump or a calf pump. This goes around your whole calf. While you're in bed, you'll have these on when you're here with us. While you're an inpatient here, we're going to give you all the home medications the doctor wants you to continue. Plus, we're going to give you a few extra things. We're going to give you 3 doses of IV antibiotic. The first one you get in the recovery room, and the next 2 you get up on the floor. We'll give you some type of an anticoagulant or a blood thinner. We want to make sure that you're not developing any blood clots. And again, that's something that's a complication that can happen after any surgery. In orthopedic, it's a little bit higher. A colace or a stool softener. Pain medication and immobility slows the motility of the bowels down. So we don't want you to get constipated. And then, of course, we'll give you your pain medication. We do purposeful rounding, the hours from 6 in the morning till 10 at night. At least every hour someone from the staff is in to see you. We want to try to foresee your needs. How's your pain? Are you comfortable in the position you're in? Do you have to get up and go to the bathroom? And do you have everything you need within your reach? Maybe you're in the chair and you want to go back to bed or vice versa. During night shift, it's every 2 hours. But just try to discuss your pain medication regimen with your night nurse before you kind of turn in for the night. So we want to make sure that if you can have something for pain maybe at 2 o'clock in the morning, you don't really sleep through it. So you want to make sure that you really have a good conversation with your night nurse about your pain medication. So you wake up the day after surgery, you got this new joint. It's an exciting new day for you. Some of the other language that you're going to hear is your call light. You always have your call light even though we purposeful round. We engage the bed alarm for every one of our patients too. We consider each one of our orthopedic patients a fall risk, so of course we don't want you to fall. So we definitely do engage the bed alarm, and the bed alarm rings into the hallway and in the nurse's station to let us know if someone's trying to get out of bed by themselves. We know you're alert and oriented. We know that you know what you're doing, and a lot of people don't want to bother the nurses. Please, we want to be bothered. We want to help you. We do not want you to fall. So we kind of purposefully put your walker, where you can't reach it either, so that we can help you out. Blood tests, your daily labs. We're going to draw labs on you every day while you're here in the morning. We want to just make sure that all your levels stay within normal limits. Again, blood loss can happen during surgery, and every so often someone needs to have a blood transfusion. Doesn't happen that often, but if it does, if your iron levels, your hemoglobin dips a little bit too low, we would send a sample of your blood down to our blood bank. It's run through hundreds of tests for compatibility. A unit is set up to the floor, and your nurse that's taking care of that day administers the blood to you via your IV. We check your vital signs every 4 hours while you're here, including your pulse oximetry. We want to make sure your oxygenation, as well as your your heart rate and your blood pressure are all okay. Foley catheter, we don't see too much anymore. If you do wake up with a Foley catheter in, we would have a standing order to remove it either that night or first thing the next morning. But we don't see too many of that. The hemovac, we don't see too much of either. But just in case you do wake up with a hemovac, we would have, the doctors would be removing this the first thing the next morning. Nursing would drain the collection of extra blood and body fluid from around that joint space. Nursing would drain this every shift and monitor the output and document that. Intake and output, we do monitor. We want to make sure that you are voiding, that you're peeing sufficiently, and also that you're drinking, and that they kind of balance. We don't want you to get dehydrated. We don't want you to go into any kind of fluid overload. And then the foot pumps and leg pumps we kind of talked about. We do in the hospital, we have soap, shampoo, toothbrush, toothpaste. You can bring your own if you want to, but you don't have to. We have that here for you. Meds to Beds is a program that we have available in the hospital. And what this is it would, if you choose to utilize it, one of the provider taking care of you would send down to our pharmacy here on the ground floor, Medcare. And they would send your one-time prescriptions that you would be getting from here. So it wouldn't be any routine medication. It wouldn't be anything that you get refills on. It's just one-time medications. They would send those scripts down to our pharmacy here. A tech from Medcare would bring them up to your room, and they collect your regular copay. And what this is, it kind of just gives you the option to not have to stop at your CVS or your Walgreens on the way home to pick up your pain medication, whatever else the doctors would be ordering for you. So it is an option that's there. Your discharge planner or social worker would talk to you a little bit about it. It isn't anything you have to do, but it's just a convenience that we do offer for our patients. There is no parking fee for guests. When you drive out today and you get to the gate, the gate is just opening right now. And if not, what that would be is we have the ability to sign for your payment of your parking. You're going to get a few business cards today. Please just make sure you utilize them if you do have any questions at all. My card is on the front of your folders. It's either mine or Renee Delmont, who's my unit manager, is on the front of those folders. Okay, that's it for my part. Paul, from therapy?
Can I just ask you a quick question?
Sure.
In this book first.
It's in the book. It's in the
Make
book.
sure. Okay.
Yeah, and what we do is when you go home and you take a look through that book, we want, any questions, that's why we give you the card.
Thank you.
Okay?
Okay. Hello everybody, my name is Paul Kelleher. I'm one of the physical therapists who works here. I just want to let you know what to expect from physical and occupational therapy the day of surgery and following that, okay? So for those of you that have surgery during the earlier part of the day, you will be seen by PT and OT that day in your room, okay? When we see you in your room, we don't do a lot. We're going to go over your exercises, your hip precautions, and if you feel well, we'll get you up out of bed and have you take a few steps, and then have you sit up in your chair, okay? For everyone else, we'll see you twice a day in the physical therapy gym, which is right down the hallway, and we'll see you right up until you go home. You can go home when you can get in and out of bed by yourself, walk by yourself, stand by yourself, and when your pain is managed. So when that happens, you can go home, okay? As far as equipment, you do not need to bring any equipment with you. Each room has its own private walker, and the gym has all the equipment you could possibly need. As far as exercises, if you wouldn't mind opening up this book to page 18, please. So I just want to go over the exercises that you're going to do on the day of surgery and following that, okay? So circle the exercises that we go over because we're not going to be doing every exercise that's in the book. So the top of page 18 is an ankle pump. So that's just pumping your ankles up and down, okay? Exercise right below that is a quad set. So with your legs straight out, all you're doing is you're pushing your knee down, okay? That's it, just pushing your knee down, contracting these muscles. So if you had like a marshmallow underneath your knee and you're trying to smush that marshmallow, that's all you're doing. You're not bending the knee, you're just pushing it down, okay? Next exercise, on the top of page 19, gluteal squeezes or butt squeezes, just squeezing your buttock muscles together, pretty basic. And exercise right below that is a heel slide, so when you're lying in your bed or reclined in a chair, it's just bending your leg up and down. That exercise is going to be the most difficult exercise to do. Don't worry about coming all the way up. Even if you can just bring your leg up just a little bit, that's great. We just want to start getting that leg moving. Okay? All right. Turn the page. We're not going to do the first two exercises at the top of page 20. We're just going to do the exercise at the bottom of page 20, which is the long arc quads. And that's when you're sitting in a chair, just kicking your leg up and down. That's it. Okay? And the one sitting in your chair, don't worry about that one on the day of surgery, okay? That would be for the day after. Now, I want you to start these exercises on the day of surgery, the first 4 that we did. So, for those of you who are not seen by physical and occupational therapy the day of surgery, because your surgery is a little later in the day, I want you to start these on your own. So, go through these at home a few times so you're familiar with them. And then on the day of surgery, once you get in your room and you're awake and you've had something to eat, go ahead and start doing these exercises. Okay? Any questions on the exercises? Okay, good. Now, hip precautions. So there's 3 things you do not want to do after surgery. Okay, they're called hip precautions. The first one is you do not want to cross your legs. So if it's your right leg that you're having the operation on, you do not want to cross that leg like this, okay? The second thing is you don't want to bring that leg back. So don't cross the leg, don't bring it back, and the last one, where it shows someone lying on their stomach, pushing themselves up, that's the third one. I mean, most people wouldn't try that, but we throw that in there just in case. The reason why you don't want to do those hip precautions is because if you do them, your hip can loosen up and pop out of socket, okay? So you're going to want to maintain those hip precautions for about 2 months. Okay? All right. Hip kit. This is a hip kit. There's different gadgets in here that will help you get dressed and bathe yourself. We sell them in our pharmacy, which is on the ground floor. When you first come into the hospital, they're about $30. You can pick these up at just about any pharmacy. We keep them here for your convenience. Do not go out and buy one now, okay? Wait till you are evaluated by the occupational therapist after surgery, and she or he will let you know if you need one. Some of you may not need this kit, but there may be those that are having a little difficulty getting your clothes on or shoes on, and these kits are very helpful, okay? So don't buy one now. Wait till you're seen by the occupational therapist, okay? Good news is everyone will be, weight bearing is tolerated through your operative leg, which means you'll be able to put as much weight through your operative leg as you can tolerate. You will not damage your hip by putting body weight through it, okay? It may hurt, but you won't damage your hip, okay? And so once you do leave here, those of you who are going directly home, you will then have home physical therapy. The home physical therapist will generally be out to the house within 24 to 48 hours. They're going to work with you right up until your follow-up visit with the doctor, which is about 10 days. At that point, the doctor will probably send you to outpatient physical therapy. Okay, so that's the protocol: physical therapy here, home therapy, and then outpatient therapy. For those of you who go to rehab, just throw rehab in the mix. So it'd be physical therapy here, rehab, home, and then outpatient. Okay, like I said, that's the general protocol, but there are exceptions. And I believe I've covered everything. Does anyone have any questions for me? No? Okay, if you do, Lynn most certainly can answer them. Okay? Okay, it was nice meeting you folks, and we will take good care of you when you come in for your surgery.
my name is Elizabeth. I'm a hospital social worker. I'm getting a little bit short on business cards, so I have 4 exactly. So I'll leave them here. If you guys want to take one when you leave, feel free to grab one. Give me a call if you have questions once you get home. So I'm going to go over a little bit about the social work and discharge planning role, and then I'll open it up to some questions if you guys have any. So it's myself, I'm a hospital social worker, and then Alyssa, she's our discharge planner. Either she or I will see you right after surgery. We're going to get to know you quick, do a little assessment with you, and then we'll kind of gear you up for your discharge. Just a show of hands, how many are thinking about rehab? Anyone? No? No? Okay. I mean, most patients want to go home if they can. So that would be our goal, is to, follow your progress with therapy and then get you linked up with home therapy. Is everyone from Erie County here? Yeah? No? Okay. Do you mind me asking what county you're from? Cattaraugus. So we would go over what options for home care are available to you, probably on admission. For everyone from Erie County, the big ones in the area for home therapy are Visiting Nurses Association, Macaulay-Seton Home Care, Will Care, Amedisys. There's a newer one called Alpine Health. Cattaraugus County, there's I think 2 that go down there, so we'll let you know which ones are available. So what we do is we'll follow your progress. Therapy will most likely recommend equipment for you, typically a walker, commode, something to make it easier for you at home. If you already have equipment, let us know so we don't order you multiple, walkers and things like that. We typically can do an insurance check, let you know if the items are covered. Normally rolling walkers are covered though. If you've never received one in the last 5 years, they should be covered. So that's kind of if you're discharging home with home care. So we would set you up with the referral to home care and then also equipment. I'll talk about rehab even though no one's really, thinking they'll need it. It is an option if you're not progressing as quickly as, we might have anticipated. It's a good option. If you don't have a lot of family support at home, it's a good option. There's a rehab on campus here called Terrace View. If you're looking to get closer to home, we would kind of review what your options are closer to home. And then we pretty much set you up. We will get you there from here to rehab. We'll make sure that it's in network with your insurance, so there shouldn't be a high cost of going to rehab. And then once you get to rehab, you'll have a new social worker and a team that will link you up with home therapy, like Paul said. It's kind of our role in a nutshell. If we can do anything else to make your stay enjoyable, please let us know. Are there any questions about discharge, about rehab, home therapy?
I do have a question.
Yeah.
Let's say things go well at the hospital and you end up at home.
Mm-hmm.
Things do not go well. Can you go to rehab from home?
That's a great question.
Or do you need to be readmitted?
It is possible. A lot of it's dependent upon your insurance. If you have straight Medicare primary A and B, you require a 3-day hospital stay to qualify you for rehab. So if you're already at home, you wouldn't qualify unless you come back to the hospital.
And you'd have to be in the hospital for 3 days initially,
Correct.
too, after surgery in order to go to rehab.
If you have Medicare, straight Medicare. If you have like a Medicare plan through Independent Health or Blue Cross Blue Shield, you do not require a 3-day hospital stay. But if you're that close, if you're getting home the next day and you're not doing well, our therapist will lean more towards rehab. So we would avoid that problem probably. So if you're kind of on the fence, whether, our therapists are like, ooh, you could get home, you could go to rehab, they would probably recommend rehab for you, just to be safer. Because we don't want to send you home and then, you're not ready to be home alone and, doing everything independently. So they would probably recommend rehab at that point for you. Yeah.
Thank you.
A good question. It is possible, it's more difficult once you leave here to get into rehab though.
And what about if you have not just Medicare, but if you have Blue Cross and Blue Shield separate from the Medicare, or if this is workman's compensation, is it still the 3-day rule?
Nope, that does not apply. Only straight Medicare Part A and B requires a 3-day hospital stay to qualify for rehab.
Okay, thank you.
So yeah, no problem. Good question. Any other questions? No? Okay. So I'll leave my card up front. If you guys think of anything when you're at home, feel free to give me a call. All right, and good luck with surgery. All right, yep.
I got a message from respiratory that he's tied up with something on the floor, so I'm just gonna go over the incentive spirometer quickly with you guys. When you wake up, when you come up to the floor after surgery, you're gonna have an incentive spirometer bedside. Your nurse is gonna show you how to use it. But this is actually just a tool to measure how deep of a breath you're taking. It's very important after surgery to take deep breaths. It's very important to cough after surgery. After anesthesia, your lungs tend to close up from the bottom up. So we want to make sure that that's not happening and to help prevent pneumonia. So your nurse is going to show you how to use this bedside. It's very simple, and like I said, it's just a tool to measure. You put your mouth around the mouthpiece and take a deep breath in. You hold it for a second or two, breathe out. This little ball here fluctuates between the arrows. You might do 1,000, you might do 4,000. Every person's different. It depends on your lung history. It depends on your age. There's a lot of things that come into play. But this is something that we are going to have bedside for you. We're going to show you how to use it after surgery and, again, go over the importance of using it. Okay? All right. Hi, Deb.
Hello, everyone. I'm Valerie Killian, and I'm here to be your resource to give you information about subacute services, not for any other reason that you should be well informed to understand. So it's a little building on what Melissa just said. First of all, I would like you all to know you should try to go home. You should try to go home. You will do best at home. You will recuperate best at home, and it is just all around better for you. However, there are going to be reasons why you should consider subacute. And just like any other plan, you should have a surgical plan. You should have ideas of what if after surgery, so you are ready for the unknowns. So if you are able to get in and out of bed by yourself or with an assisted device, meaning a cane or a walker, or the help of another person, you're able to get up and down from a chair. You're able to walk in and out of your kitchen to get simple meal prep, meaning you can get yourself a drink and also make something simple to eat, not on a stovetop even, just something simple such as a sandwich. And you can get yourself in and out of the bathroom on your own or with a device or with another person. You should not need rehab. Now, however, there are going to be reasons why everything doesn't always work out. So let me just tell you what subacute rehab is. It is extended stay beyond hospital stay. So you come in and you have your surgery, and then you're there for your 2 or 3 days, depending on your insurance and depending on how well you're doing. And you realize that that person that was going to help you is no longer available, or those 18 stairs that are very vertical in your old Buffalo home don't work as well either for what you need to do, and you just need that extra little bit of help. That's where subacute comes into play, and that's where you should have the idea about going. So think about it ahead of time. Pick a place, go visit, never go any place blind. You're going to be post-operative anesthesia. It might alter the way you feel. You might be a little bit more emotional. So if you think you're going into this room that is 5-star hotel and it's a great place, it just might not be what you had in your mind. So always visit ahead of time and always make a pre-application ahead of time. You don't want to just wait to see what's available. Busy time of year is 24/7, all 12 months in Buffalo for surgeries and rehabs. So always call ahead. So with that in mind, with subacute rehab, you shouldn't go if you only need a couple days of rehab. You really should need at least 3 to 5 days of rehab to make it worth your while. Because majority of rehabs, whether they are for-profit or non-for-profit in Western New York, the first day you get there, it's a nurse evaluation. Next morning, physical and occupational therapy come and they evaluate you, and then by that next day in the afternoon, you're going to your actual therapy. So with that being known, here's some other things you should think about. Is the place close to my home? Does it fit my needs? Is it convenient for me and my family? Does it suit what I'm looking for? Does it have private rooms? Does it have private showers? Does it have a gym separated by a hallway with only subacute patients? More importantly, for orthopedic patients, are you on an orthopedic floor only, meaning they don't allow infections to come to that floor? You have brand new joints. They're very important to your surgeons. You've picked a great place to have your surgery. We have a 0 infection rate. You're doing wonderful. You don't want to go a place that doesn't follow that same suit. So you want to ask that question, am I with like patients, meaning orthopedics? That's very important. Find out how many days a week that you are going to get your rehab. If it's only 5 days a week, that might not work with you. You know, knees and hips should get 6 to 7, all right? So with that being said, always pre-apply. You can always cancel. No subacute service in Western New York should charge you for a cancellation. So it's like a hotel where you can make your appointment, you can make your reservation, and you can cancel it without penalty. Also, you shouldn't have to fill out an hour's worth of paperwork to go to subacute rehab. The basic necessities are that they know your name, your date of birth, the date of your surgery, who your surgeon is, and what your main insurance company is, because they want to make sure that they have a contract with your insurance company so you can go there. Those are your mainstays that you should realize. Of course, I know Melissa mentioned that we have subacute here at Terrace View. Our building is on the campus. It is very convenient to be attached to a hospital. We have 400 beds. The hospital is 600 combined. We're a 1,000-bed campus. And we have a very widespread variety of services here that you would not need to travel but through a tunnel, being walked through or pushed through in a wheelchair if you so need it. So with that being said, I'm just going to let you know, I'll give you my card. If you have any questions, give me a call because I'm your resource for all subacutes so you understand the concept. And if you want more specific questions about Terrace View, you can give me a call. Okay? All right. Good luck to you guys. There you go.
Good morning. My name is Kathy. I'm a liaison with the Visiting Nurses Association, one of the home health agencies that you could potentially go home with. I'm here right on site. I work very closely with discharge planning, so they'll let me know if you're interested in going home with home health through our agency. And then I would come down and visit with you, make sure that you are ready to go, answer any of your questions, confirm all of your contact information and so forth. What we have to offer is when you do go home, we can guarantee a physical therapist come to your house within a 24-hour period. So if you go home on a Monday, we'll get you to be seen the following Tuesday, okay? So that physical therapist will come to your house. First they'll call, they'll schedule an appointment, they'll come to your house. They'll spend roughly about an hour, hour and a half with you at that very first visit. They'll do a complete assessment, and then based on that assessment, they'll let you know how many times he or she will be coming to your house. Then you'll go to your follow-up, talk it over with your surgeon, and then they'll reassess at that point in time. We service all of Western New York. We take all insurances. There's an occasional funny one that comes along. We'll do an insurance check on it and let you know what your responsibility is. And we're a 4.5-star agency, and we take great pride in that, always striving to take care of our patients and give you the top care that you deserve, okay? Any questions or concerns? It's a very easy transition, and we'll do all the work for you. Any questions? Here you go.
Thank you.
This is just some information for you. Yeah, sure. Would you like one too? No. Oh, okay. Here, take one. Okay. Go ahead. She's the
Does anybody have
advocate.
any questions at all?
Good luck.
Thank you.
Okay. You got a few different business cards today. Please don't hesitate to use them. Like I said, you either have my card or Renee's card on the front of your folder. We work very close together, so if you do have any questions, you can give either one of us a call. Okay? All right, we'll take a walk down and see the therapy gym if you want to. Otherwise, we are all set. Thank you.